Welcome.
Yeah. Thank you. Thanks for
having
having
me. So we do it in English because you come from
the United States and the state of Virginia on the East Coast, right by Washington, D.C.
Yeah. Robert, it's really an honor that you are here. And that is because of Brecht Arnold. He invites you to Belgium, if I'm right.
Just so. He had a barbecue yesterday.
Oh, you have a barbecue.
In which, because it was very informal, in which we were able to, many of us, including Matthias and Gert,
Matthias is met, yes.
And Gert van den Bossche, were able to speak to an invited audience of free thinkers, people that were open in their minds to considering things that aren't usually in the media. And it was a great pleasure to speak openly and freely and learn also from my colleagues here in the lowlands. In the United States, we're very aware of the bravery and leadership of the farmers here in the lowlands, and very interested in understanding their point of view and their bravery, which is very similar to that of the truckers in Canada. Yeah. And so when I was invited to speak by Brecht, I was very glad to accept, both because of the opportunity to learn and speak with these open-minded intellectuals, which seem to be occurring in this small country, and providing intellectual leadership like Theo and Matthias and Gert, and also to learn. I'm here to learn from my colleagues about how they see the world, so that I can bring back that learning to the United States and share it with my colleagues, so that we have better alignment. I think one of the things that has become clear throughout this outbreak is that there has been a globally coordinated propaganda and public policy, and it has been confusing.
It's very confusing. We speak a lot here in this room with Matthias de Smet about that problem. I think he's the best in that subject. So today, also Theo Schetters here. And to introduce you, you an American physician, biochemist, and you are part of our work. You focus on the mRNA technology. And or gene therapy, how can I say it?
It was, so this is one of these early topics that I touched on that resulted in this very disproportionate response in the corporate media.
Yeah, but I know you from Brett Weinstein, his podcast Dark Horses. I think that was the starting point, and after that, Big by Joe Rogan.
Actually, the first podcast, so for me, I mean, I know for all of us, the podcast has been a journey. And my very first podcast was with a interviewer based in New York who asked me about antibody-dependent enhancement. And so it's that journey of starting with just trying to help people to understand what antibody-dependent enhancement was, through this stepwise progression that has led me to this point and to your door. But through it, it has been a conscious decision on the part of myself and my partner, Dr. Joe Glaspel Malone, when we encountered the propaganda, censorship, defamation strategies of corporate media, that the only way that we hypothesized that the only way that we would be able to share the information that we knew to be true was if we threw ourselves into this new medium of the podcast in particular, which we were ignorant about. I was so afraid when I first started doing it.
But now you're a pro, I think.
Now I'm actually, people are using me as an actor now.
Yeah. Oh, really?
Yeah, it's a very strange progression that I've had.
Just say that, or something like that? Just say your lines? Or
scripts, in particular, Mickey Willis has both interviewed me for his Plandemic series as a scientist and a thought leader, but also asked me to function as an actor in some of the things that he's doing, including one that will be coming up fairly soon. That is a spoof of a American beer commercial. So stay tuned for that. But it has been. I've had to learn all of these skills of communication.
I know, Robert. I'm kind of famous in the Netherlands, and I know what you mean, what you all have to do. But we are really interested in you because you, for especially by Brett Weinstein, you are in the very beginning. You kind of much more than we from mRna, and you said be aware what you go to do. And it was very fascinating that we think, what? The government says something different. So what are the points? So then now we go fast forward. If people want to know more, but we have limited of time here, then please go listen to Joe Rogan, or I can't find any more your podcast from Brett Weinstein. It's already skipped also?
It's still out there.
It's still out there. So people can find that.
You may wish to look. YouTube is highly censored now.
Yeah.
At the time, the censorship was emerging, and now it's florid. So many have migrated to Rumble.
Yeah.
And then the problem is, of course, that Google actively manipulates the searching algorithm, as they did when I first spoke these three words, mass formation psychosis.
Yeah, what you have from Matthias, that goes viral, and that is the connection, I think, with you and Matthias, because you mentioned by Joe Rogan.
It certainly was a milestone. But my point is that to find these things, often one has to use alternative search engines. Yeah. I personally use the browser tool called Brave.
Me too.
Yeah, me too. Yeah.
And you can find things more easily there.
Yeah. But fast forward, now we are here. So you are the one who raised the red flag already very early. Theo is here. So I want to try to pick your heads both. Where are we now? Perhaps, Theo, you can explain a bit how we did it in the Netherlands, because you even didn't know exactly if you were in the Netherlands or not. But because all areas has its own way of doing it, so perhaps you can explain, and then we can start discussion. Where are we now? And how are we going further?
Exactly. Well, in the Netherlands, we don't have somebody like Brett Weinstein. So I spoke out, that was in January 6th, actually at the day the first vaccination was given to a medic or a nurse. And I just said, like you said, this is not well researched. This is very irresponsible to start vaccinating the whole world with this material. You don't know the safety of it. I didn't believe in the efficacy at all. But of course I'm a scientist, so you have to wait for the results. Yeah. So that was then. And now we are at a point where we see the results coming. So the things that we said right in the beginning, that vaccination against a respiratory disease by intramuscular injection is most likely not going to prevent any transmission, because you then talk about systemic immunity, which you actually evoke, and as opposed to mucosal immunity.
Just so.
Simple, yeah. So that became clear. The other thing was that we knew it is a very mutating virus. So I always said, it's like you run with your syringe behind the virus that's running away from you. And so you can never keep up with the mutations. And actually that's what we see. So also the Netherlands, the National Institute of Health, has said that people that have been vaccinated twice with the original vaccine, that at the moment there is zero protection anymore. So that's official result. That on the efficacy side. And then on the safety side, we also see problems. And that's the most difficult part, because people do not want to talk about the safety. You know, there's so many people that contact me because in the Netherlands I'm some sort of famous if it is about this. So I get emails and phone calls of people who have had very bad experiences after vaccination. And the sad thing is that although these people sort of obeyed the rules of the government and trusted them, now that they have these terrible side effects, the government doesn't want to listen. You know, so you just neglect it. We don't talk about it. And that's the situation at the moment. And as I said, it's I sometimes make the comparison that there was a murder and the body was thrown into the lake, and after a certain time that body surfaces. And this is what we see happening now. And that's a very difficult story.
Yeah, and perhaps something just, you know, we are different cultures here. We believe, as people who live in the Netherlands, that we are a very open culture.
Yeah.
And that we can talk about everything. And about the good and the bad. And also in science we have a very open culture. Perhaps we are not the best, but we are very open-minded.
Well, you also, just to say it, in the world of virology, particularly veterinary virology, the lowlands have long been recognized as having particular excellence in virology, and a unique way of thinking about particularly veterinary virology that comes from a commitment to food integrity, is my understanding, and the belief that vaccines are a tool which should be deployed carefully and logically, because of the awareness in the food veterinary virology practice that vaccines can result in a situation where you enhance chronic infection, endemic circulation of pathogens, and that there are situations in which the culling of a swine herd or a avian flock can be more appropriate than the vaccination of that, which obviously we cannot apply that directly to humans because of ethics, but there is this long history of independent thought in excellence in virology, in particular in the Netherlands, that I think often gets overlooked. But I, in my early training, was taught to recognize and respect the excellence of the lowland virology community, particularly in animal science.
Yeah, that's actually the vet schools of Ghent and of Utrecht are top veterinary schools. So that's where it comes from. But if you make the comparison, if I may,
yes, please.
When you talk about the use of vaccines in animal production, you have to realize that the animals are every time naive in animal production. And that's why the dynamics there is completely different from what we see in humans, because we are not naive. Right? So,
particularly to coronaviruses.
Yeah, exactly. But also, so what I'm trying to say is that so we get our childhood vaccination and then we are immune for life. But with chicken farming, it's not. You have the chicken there, and after 6 weeks you have a new flock, and they're all naive again. So there's a completely different dynamics there.
True.
And so that's what people have to understand, that it is classic immunology, of course. We have immune memory. which means that if we have seen it and we've survived it, then we are protected for a lifetime until the moment that, of course, due to senescence and aging, our immune system starts decaying and we become vulnerable again.
Well, there's also, so this immune memory, like everything, is a double-edged sword. It has benefits and it has consequences. And we're now seeing the emergence of one of those unfortunate consequences.
Yes.
And the language that we use, the words that we use to call this phenomena are immune imprinting,
yeah.
or the synonym, which is more sexy, original antigenic sin.
Yeah.
But can you, because that was really one of my questions, what is immune imprinting?
So Theo was just introducing us to that concept. In a way, it's one of these, you can look at it in different ways. When our immune system, by the way, our immune system is derived from the same embryonic source that our nervous system is. Our immune system and our nervous system are both incredibly complex. I think as biologists, it's important to acknowledge that these systems are so complex that we're still students. We're still learning of the underlying complexity in comprehending these interactions. And in the case of our immune system, the simple way that I try to convey this very complicated idea of immune imprinting or original antigenic sin is that we all know that as children and as adults, we experience the world. And the things which we experience bias how we respond in the future. The same is true with our immune system. One of the things that's a fascinating nuance about our immune system is this incredibly complex, adaptive, so we're talking about the more evolved, immune system is like layers of a cake. These different types of immunity that go back to primordial organisms, okay? But in the more recently evolved organisms like mammals, there are these adaptive immune systems that we commonly call, we throw these words around, B cells and T cells, that learn. And they learn in a strange way. They actually evolve their response genetically. It's fascinating. Yeah. 2 Nobel Prizes for this, yeah. Okay? That our immune system actually evolves in response to the antigens that it encounters. The thymus is one of the key organs for this, yeah. And it relates to why children are so much better able to respond to new pathogens is they have this, you could think of the thymus as the school, the university for your T cell response. And in children, it's very well developed. It's a big campus, the thymus. Yeah. Yeah. And then it gradually collapses. But in the children, it's very actively educating. So what happens is that when we're children or adults, and we encounter something new, a new antigen, which is different from our normal antigens, ourself, our immune system develops cells that react to that. And it's a very complicated process wherein some of these cells are selected and they grow out, and other ones are suppressed that might react to that but less effectively. And the end product is a form of memory, just like in our brain, but it's a very discrete memory. It is a population of cells, which we call memory cells, that are preserved in our bodies as essentially the memory of our immune system about that pathogen. So if we encounter that antigen, that new thing, that coronavirus spike, from this particular coronavirus, from Wuhan 1, we have these cells in our body that are ready to respond to it. What happens with immune imprinting or original antigenic sin, by the way, it also happens with influenza vaccines, is that when one repeatedly administers these vaccines, we'll call them vaccines, that are based on a historic virus that no longer circulates, it trains these educated cells, these memory cells, to only respond to that one thing. it trains in a fascinating way. It says all other cells that sort of react to this, but not as efficiently, should die out. And only these ones that are very efficient at reacting to this thing should be preserved. The consequence is that if we now encounter a new version of this virus, which is what we have, let's say, just for sake of argument, Omicron. Let's say Omicron, the slang is ninja. Ooh, that's scary. BA5, the latest currently circulating that is now ending in South Africa. It's almost gone. Okay, but there is a fascinating body of literature now. It's very hard to do this immunology from all over the world that shows that this prior exposure to Wuhan 1, followed by the repeated dosing with Wuhan 1 spike, trains your immune system to focus just on that Wuhan 1.
And forgot Omicron.
And then, well, I wouldn't say forgot Omicron. It is so highly educated. It's like the physicist who is so focused on string theory that he doesn't understand Newtonian physics, right? It's akin to that, okay? So these cells are so focused on Wuhan 1 that Omicron has evolved to escape these types of responses. So it's not that it's forgotten. It's that Omicron has exploited the fact that we have trained all of our immune systems by this repeated administration of a spike antigen that, for a virus that doesn't exist anymore, doesn't circulate. And so it's created sort of a blindness in all of our immune systems that have taken this repeated vaccination. So I hope that this is a very complicated idea, immune imprinting, but in a sense it's very simple. What it is if you think about a warfare metaphor, the army is always prepared like the Maginot Line, okay? The French before World War II, right? The army is always prepared for the last war. The same happens with your immune system, and if the enemy, in this case the virus, changes itself, using the metaphor, this would be the German blitzkrieg, right? The enemy has adapted to that situation. It's figured out how to get around the Maginot Line, and it blows right through it. And it's even worse than that, because of this phenomena. There's a recent science paper published about 3 weeks ago now from our current recording date, that from a UK team that looked at healthcare workers over time, very solid study, on top of many other solid studies, that shows that these people that had early Wuhan, then the repeated dosing, and then get exposed to Omicron, actually develop an immune deficit. So their memory cells actually are less reactive when they encounter these new Omicron strains. And this appears to explain, there's many different, the clinical observation is that all over the world, what one is seeing in the data from governments all over the world is this odd phenomena that the people that are highly inoculated, those that are fully compliant with the government directive, they've received all these boosters, are the ones that are dominating hospitalization and death. Now there's various forms of artifacts within that data, but at the high level, that's the truth. You cannot debate it. All we can do is argue the nuance. And so the question is, how could this be? And how could it be that repeated vaccination, which we've all been told would protect from infection, replication, and spread and disease, that was the fallback. We used the slang in the Americas, the modified limited hangout, was that, well, it doesn't protect against infection. Well, it doesn't protect against replication. Well, it doesn't protect against spread, but at least it protects against disease. And now all the data show that that's not even true. And so the why is this. And it isn't necessarily all due to immune imprinting, but in my mind, as I look at the data, peer-reviewed, high-profile publications, the immune imprinting data are very, very solid and strong, as certainly a major contributor to this paradoxical effect.
Maybe I could add something with regard to rising of variants, because some people give the idea that because of the vaccination the virus changes, and that's not what I think. What I think is that these viruses change anyhow. So because of developing immunity, only the ones that are not recognized or killed by your immune system are the ones that will survive. That's also normal Darwinism, evolution. We are here because we survived until this moment in time and in history, and not on a sort of purpose.
The idea of Richard Dawkins that we're all just carriers of genes through time.
Yeah, so that's, I think, important to realize. Right? And the other thing is with regard to immune imprinting, of course, that plays a role, but also what plays a role, and that's that paper, also the people, group in the Netherlands from Radboud University contributed to that, is they have shown when people are vaccinated with mRNA vaccine that there is a sort of reprogramming of your immune cells. And so they've measured that there's a different response of the white blood cells of those people against viruses, bacteria, fungi, and even against tumors. That paper that was on the preprint server in May last year, and it's still not formally peer-reviewed and published, which I think, and then we come to censorship, is because it is a very inconvenient message that by vaccination with an mRNA vaccine, you change the core of your immune system.
That's why that's why I call it organ therapy. So it's very difficult to say it like that, but you are one of the inventors. You already published in 1989 about this. So how do you see that? What can that mRNA do?
There's a couple of threads that touch on this. I'd like to start off with the language, the words, because words matter. Words are being very actively, the meaning of words, the meaning of vaccine, the meaning of being an anti-vaxxer is now, for instance, redefined as anyone who has vaccine concerns or hesitancy is now an anti-vaxxer, formally defined. In the dictionaries, okay? There's been an active manipulation of words. When I spoke on Brett Weinstein, and subsequently, that in fact, these are gene therapy technology applied to the indication, the medical indication of vaccination, there was an immediate censoring and defamation response with all the fact checkers. I find it very useful. My colleague Nick Hudson, who is a South African actuary with key leaders of Panda, shared an idea with me recently that I find really useful. You can perceive the very sensitive topics by watching for a phenomenon that he calls the electric fence. There's an electric fence that gets built by the propagandists around any topic that is particularly sensitive to them. And if you touch on that, if you say words that relate to that, you will get an immediate response like a shock from an electric fence. And in this way, you can see what are the most sensitive topics, okay? So, for instance, when I said mass formation psychosis on the Rogan show, it provoked this immediate knee-jerk response. Google started editing queries in real time. The press, international press, immediately attacked that. And they attacked and they tried to delegitimize Matthias and the logic, and yet it's a logic that goes all the way back to Plato and the allegory of the cave. I mean, this is ancient, fundamental academic knowledge. Okay, so these words that this is actually a gene therapy also provoked that. Now the question is why? And if you look at the Security and Exchange Commission documents filed by BioNTech and Moderna before all this happened, they explicitly acknowledge that this is gene therapy technology. It's part of their required disclosures to their investors, where they speak about the risks. Okay, so this immediate reaction in me saying these words, "This is gene therapy technology," was a revealing response that there was something very sensitive about using that language. So then the question is why?
Yeah,
why are they so
sensitive
sensitive to this?
Yeah.
Okay, I have come to conclude that the reason is because the regulatory authorities, following the lead of FDA, I mean, this whole story has been really driven by a small cadre of appointed leaders under Mike Pence during the Trump administration, I'm being honest, okay, which one of the key leaders it's turned out is Deborah Birx. Deborah Birx, together with Bob Redfield, who are both partners in the AIDS world, particularly in PEPFAR, the African AIDS Initiative. Okay, so they have this long history of working together. And they were put into their positions of power, her as Ambassador Birx on the Vice President's Committee for Response to the Coronavirus, and Bob Redfield as head of the CDC. And they basically created a narrative and a strategy which they borrowed directly from the Central Communist Party of China. So the lockdowns and all those things, Deborah Birx now has written this book in which she openly admits that she accepted what we now know to be the propaganda coming from the CCP to the West and implemented it very aggressively. And part of that was the decision at the FDA level to employ the checklist, because FDA these days is very checklist driven, as is EMA. The regulators have checklists in which they say this is a product of this category type, and therefore the steps that have to be taken are these. Here's the checklist. And they employed the vaccine checklist under the assumption that this was a classical vaccine technology, which it wasn't. They explicitly acknowledged that in the regulatory documents, but they elected, under political pressure from Mark Meadows, who, in the office of the president, they elected to expedite all of this, to cut corners. It's the historic record.
Same.
And one of the things they did was they chose to not treat this as gene therapy, because gene therapy has a whole different checklist. If it was a gene therapy, they would have had to do these tests about genotoxicity and other things. And since they employed only the vaccine checklist, they avoided doing those tests, requiring those tests. And there's a bunch of things they let Pfizer and Moderna and BioNTech get away with beyond this, that not only did they waive that, but they didn't even apply the full normal checklist that they would do, like biodistribution, pharmacokinetics, and these kinds of things. They bypassed all of that. But in particular, if this is a gene therapy technology, which it is, then they should have employed the gene therapy checklist. And I think this is why this immense reaction is that by saying this is a gene therapy, using those words, what it does is it clearly demonstrates the failure of the regulatory authorities to follow their own guidance and employ the checklist that they should have used for a gene therapy technology. And for me, when I was encountering this, before we know so much more now than we knew then, I was only saying, look, I invented this technology. I was at a gene therapy lab. It was explicitly an outgrowth of gene therapy research.
For cancer?
And no, it was my focus at the time was trying to help advance the technology of retroviral vectors. And it was through a series of circumstances that I've talked at hours on other podcasts that I came to realize that there was a fundamental flaw in the logic of gene therapy as promoted by Theodore Friedman in the 70s. That this pediatrician who posited the idea that we could treat genetic inborn errors of metabolism, genetic disease in children, by giving them the good gene. And it sounds very noble. It's one of these things that on the surface it sounds so compelling. Johnny has muscular dystrophy. All we have to do is give the correct dystrophin gene to Johnny.
It's a dream.
And then Johnny will be corrected. Or adenosine deaminase deficiency, or we could go on with the inborn errors of metabolism in children, sickle cell anemia. Okay, this simple idea. All we need to do is give the correct gene. In addition to the fundamental technology problems, which, for instance, Klaus Schwab and his colleagues completely disregard when they talk about transhumanism and gene therapy. Okay, technically, none of these technologies are sufficiently efficient that we can actually create superhumans. Okay, They get tiny numbers of cells, but the logic that we can correct genetic defects completely missed the immune system. Okay, because what was learned and was strangely first encountered at the Salk Institute in the laboratory that where I was at Inderverma in the molecular biology and virology labs, working with here's a name that's well known here in the Netherlands, Dinko Valerio. Dinko Valerio was the senior postdoc in the laboratory. He was working on a whole new gene delivery technology involving a cold virus called adenovirus. And he left the laboratory and he created a new company called Crucell, which is known here in the Netherlands a little bit. And he came to me a few years after creating the company at a conference, and he said, "Robert, you're right. We need to pivot Crucell from focusing on gene therapy to focusing on vaccines." And the problem is that was discovered, and I interpreted it was an experiment done by Dr. Dan St. Louis in the lab, who found this problem. He would do a gene transfer experiment in mice, and the mice would produce the transgene protein for about 2 to 3 weeks, and then it would stop expressing. And I'm here surrounded by some of the best minds in the world in gene expression and oncogenes and regulation, and everybody thought it had to be a very sophisticated genetic mechanism. And I had just finished 2 years of medical school, and I went to the textbooks and I said, immune response timeline, loss of gene expression timeline, they're the same thing. And so the hypothesis that the real problem was that the mice were making an immune response against the transgene, which means that the whole discipline that I had chosen to invest my life in, I wanted to be a gene therapist and an MD, suddenly went right out the window. It was not feasible. And that's turned out to be the case. The only places where gene therapy is working to any extent is in these privileged compartments like the eye that don't have much of an immune response, or you have to immunosuppress the patient just like you do with a transplant. So that was the genesis of all of this, is the recognition that any gene therapy, whether it's RNA, DNA, adenovirus, retrovirus, adeno-associated, whatever your tech is, it has a fundamental logic flaw, and that is the immune system. But the synthesis that happened because I was there at the right time with an open mind and young and didn't know any better was, we can take the lemon, the gene therapy isn't going to work because of the immune response, and turn it into the lemonade of using it to produce a vaccine. So all of this talk is just obfuscation. It's a fog that's been put out intentionally to obscure the fact this is explicitly a gene therapy tech. So thank you for allowing me to riff on that.
No, it's so great that you explain it to us, but Theo, sorry, because I really want to ask you something. if you listen to the government and you trust this, and you don't go like more interested people go to the podcast from Brett Weinstein and listen to Malone, or you also try to raise your voice from the beginning, and you already have it in you. And now you hear it's gen therapy, then I think you're freaking out. So what can you help us to keep breathing?
First, I would like to comment on one of the things that you touched upon, which I think not here maybe, but in the public we should discuss. These vaccines are here on the market. These companies, they earn an awful lot of money. Why aren't these companies not doing the research that we ask for? Because now, if we talk about, is there any risk that you get change in your DNA because of this technology? That's now been done by academics, by research groups who do it on Fridays afternoons because nobody wants them to do it. And that's what now happens. Whilst these companies have the money and the means and everything to do that. So that's.
I'd like to comment on that really quick. I'll be concise.
Yeah.
You come from more of an academic background. I come from this hybrid background of nonprofits, academia, industry, government. I've seen it all. The rule in drug development, if you're in the pharmaceutical industry, is you never ask any question that you aren't forced to ask. Because you may get an answer that you don't like.
Yeah, exactly. Yeah.
And this is explicit. And so the reason why frankly, bluntly, the reason why the pharmaceutical companies are not doing it is it's not in their financial interest to do so. And the regulators have failed in doing their job, in requiring that FDA, EMA, fill in the blank, okay? The global regulatory community has failed to do its job of insisting on the correct application of the guidance in the International Committee on Harmonization and the EMA and FDA regs to insist that the pharmaceutical industry does its job.
Yeah.
That's how that ecosystem works.
Yeah.
Pharma will not do those studies, and governments will not fund those studies unless there is a forcing function that says you will do those studies because we have all agreed, and we have. All of the regulations and documentation say that these things should have been done.
Yeah, exactly.
And there was a conscious decision to not. So this wasn't overlooked.
No, I agree.
There was a conscious decision to not force the pharmaceutical companies to do the things that the regulations that we've all agreed upon over decades
just thrown
required
away.
That they should be done.
Yeah. So that's on that side. Then coming back to your question, Marlies, is that, so how are we going to sort of bring this message to the public? Most of the people are vaccinated in the Netherlands. It's something like 75%. So you cannot freak them out by saying you have something in your body that's going to be at the end of your life. And
Is it so strong?
No, because that's what I'm trying to say. In all fairness, it isn't that strong. So you have to, we know that it's not like that everybody is dying within a year after he was vaccinated, but a certain percentage of the people has big problems with this. And the point is that I think we have to be open and fair about this, not only because of the corona vaccines, but because what we see happening is that this technology is being sort of introduced as we've used it in corona, it's accepted, everybody knows that, mRNA vaccines,
Influenza, monkeypox.
Exactly. So, and that's why we're fighting against, because we say this technology is not mature. Maybe it can do something in the future, but we are certainly not at the point now to develop all these other vaccines or variants, like an Omicron variant corona vaccine with the same technology. No, because you didn't solve that problem. And we have that problem. We have a problem of people dying after vaccination. And
getting sick.
And getting sick.
Including the children.
Yeah.
And, so what do we know now
having
about
reproductive health consequences.
Yes.
So what do we now know then about the side effects? So this is the future.
Yeah.
Sounds horrible to me, but in the now, what can people be aware of? What kind of complaints that they can have, of what kind of that they now listen to this and think, what? It's connected perhaps to the vaccine.
Well, that's the problem with this technology, because this mRNA it travels through your body because of the LNP that they used.
Which physicians were told was not the case.
Yeah.
No, it should stay in the arm.
But it does. So potentially it affects all organs. And that's what the medical doctors now see. They see all sorts of symptoms that they do not know what it is. And because the adverse events are so not just single one adverse events, but can be anything. They surface very difficult to a statistical level. And that's why we do analysis on all-cause mortality. Because say, okay, if we do not know what is exactly related to vaccination, of course the coagulation problems, myocarditis, we know that. But there are many more things happening at the moment. And so that's why we look at all-cause mortality. And in the Netherlands now, it's very clear that there is a good correlation between the number of vaccinations that are given to people and the number of people that die within a week after that. So let's say in this week we gave 10,000 vaccinations, then in this week we have something like 125 excess in death in that week.
And what kind of data then you use?
I use the data from the Central Bureau of Statistics and of our National Institute of Health. And the point is that they report that every week. They do not report the graphs that we make. So what they do is they show the cumulative build-up of the number of people that have received the vaccination, the fourth injection. So then you see a curve that it goes up. You do not see the change per week. But if you calculate the change per week, and you then take the figures from the Central Bureau of Statistics, where they present you the excess mortality, that follows the same dynamics, the same.
So if you have more vaccines in that week, then you also have more excess death.
Yes.
If you have less vaccines in that week, you have
fewer
death.
Yeah.
But that is, I got goosebumps.
And the point is, of course, we do not get the real, what we call the granular data, which means that we do not have this from person by person. These are group type figures. So that group received that a number of vaccines, and in that age group you see this number of excess mortality, but we do not know whether this is really correlated one by one. And so that's why we ask for more data, because Ronald Meester said here, Ronald Meester is a professor in statistics, and we've discussed it here and said, okay, give us those data within a week. We know what's happening. Simple. But we don't get the data, so that leaves us with a correlation, with an observation. But I think by now it's getting so strong that at least, if you talk about precautionary measures, that's the way they sold the vaccines actually. They sold them as precautionary measures, so to keep us safe. Then I would say, I use the same argument now. If I see these correlations, although I cannot prove causality at the moment, from a precautionary measure, you should say, let's stop this.
Because better safe than sorry.
Because imagine if that is true. Imagine it's half true. The figure
but it's the data from what they give you by themselves.
He's making a key point, and he's being very precise, academically precise and responsible. He is not saying that this proves that the vaccine is causing this excess mortality. He is saying that there is a statistical correlation. And I'd like to emphasize a couple things about this. In the FDA's own guidance for designing clinical trials for coronavirus vaccines, and for coronavirus therapeutics, one of their required endpoints is all-cause mortality. As a clinical trial specialist, this is always the case, is that one has to look at all-cause mortality. I'm going to give you an example to illustrate this, why this is important. In the development of the anti-cholesterol drugs.
Oh, that's a well-known drug.
There was, so it illustrates the point very nicely.
Yeah.
Okay. In the development of the anti-cholesterol drugs, the logic was clear and compelling. There was a correlation between cholesterol levels and myocardial infarction. And there was a clear demonstration that this new drug technology would allow the reduction in the cholesterol levels. And so on the basis of this, there was a decision to license. And then as time went by, there was this paradoxical signal that came up again and again that all-cause mortality was actually up in people receiving these. Totally doesn't make any sense. Mm-hmm. Cholesterol involved in myocardial infarction, drop the cholesterol. You should, just as the same as now, come out with the thinking behind the SSRI inhibitors that's now documented in this last week, that in fact there is not a correlation between a biochemical imbalance and depression. That was a false thing that's been taught to medical students for years and years and years. Yeah. Same thing with the cholesterol. And the paradox was revealed when they started to dissect the data. They found that there was an increase in depression and suicide with the people that had plummeted their cholesterol levels, because our brains need cholesterol. Yeah. Who would have thought that dropping cholesterol, we didn't know this before, we only detected it by looking at all-cause mortality. So all-cause mortality is the ultimate indicator for things that we didn't expect. Yeah. And that's why we always have to have it in clinical research. And yet, once again, like so many other things, we have disregarded the learning of decades and denied the importance of all-cause mortality. And then we had this separate data set, these different people come in. They are the insurance industry actuaries. Mm-hmm. The life insurance industry makes its money by knowing precisely
it's cynical,
the incidence of death, okay, in different age brackets with different risk factors. They know this precisely, down to the sub-decimal.
It costs their money.
Because it's how they make their money. It's on the margins, okay? And there was this early signal last fall with a CEO of a multi-billion-dollar insurance company in the Midwest in the United States that said that we are seeing an unexplained increase in mortality that is 3 standard deviations. So this is statistical talk. Yeah. What it means is that's highly improbable to just be random, like highly, highly improbable. 3 standard deviations above the mean increase 40% in all-cause mortality in the bracket of the employed, because that was their customer base, was employed individuals who have life insurance policies, 18 to 64, people that shouldn't be dying, had this inexplicable increase in all-cause mortality that was no one could understand. Now, part of this is because of groupthink. No one is willing to allow themselves to imagine that this could be the consequence of the vaccination. And so we ended up with this hunt. Why could this possibly happen? This sudden jump in mortality. Is it due to the virus? Hard to say. Difficult to pull that out of the data. And so over time, more and more and more data, more and more analysis. And Theo represents kind of the latest, most precise version of this analysis, showing this tight correlation, statistically significant. And I think that's the importance, is it's not just his observation with these data. It comes on top of observation after observation after observation, including independent databases that are not subject to, let's say, government manipulations or underreporting or biases in hospitals about reporting correlations, because it's just deaths. I mean, when somebody dies, it's a very discrete endpoint. Yeah. You can't debate it. It's death.
You don't have to be a medic to see death or alive. That's good, because otherwise you end up with an interpretation of a medic who
which is subjective,
and that's very subjective. You know, we have
so it's kind of the golden rule.
Some pathologists here who say, well, you can never know what the cause of death is if you do not do an autopsy.
Which is another thing, is there has been a paradoxical prohibition on autopsies. Mm-hmm. My colleagues like Ed Dowd, who are in the investment community, are able to say words that we as scientists and physicians are disallowed from saying. Mm-hmm. And what those in that insurance and investment community, like Ed Dowd, are able to say is that, in their opinion, as they advise investors, when they perceive certain things, they can presume that there is underlying fraud. And when they observe these practices of suppression of information and unwillingness to disclose information, such as you're experiencing, I'm not saying that this is fraud, but they say that these are, as investors and investor guidance specialists, their interpretation is, when you see these behaviors of hiding information, failure to disclose, it is considered from an investor point of view to be evidence of fraud. Mm-hmm. Okay?
At least it's a red flag.
And what are you going, one moment, Robert, what are you going to do now with this big bomb, or how do you have to call it?
Yeah.
Because the Volkskrant, that's a big newspaper in the Netherlands, Maarten Keulemans, he referenced to the CDC, and they said, vaccination works. Mm-hmm. So it's for people also so confusing.
Well, that makes me think of the paper of Christina Stable-Ben. You know, she looked at the total effect of mRNA vaccination, compared that with vector vaccines. And what she saw in her analysis is that there was indeed a positive effect measurable from mRNA vaccination, but at the end, bottom line, there was no positive effect. So there must, in that group, also be a negative effect. And that's the all-cause mortality that is showing you that. So that's the same thing here. And I think we have to be careful in formulating the message. Like you asked earlier, I'm not saying that everybody who has been vaccinated with mRNA is going to die within 10 years. I'm not saying that.
Yeah, because this paper said it can also, by a part of the group perhaps, has a good influence, that it's the chance that you're going to die reduce.
Yeah, it's what but that's an immunological thing.
Maybe that's what the CDC said.
Can I speak to that?
Yeah.
On President's Day this year in the United States, so this is a national holiday, President's Day, it's in February, the New York Times published a paper in which the New York Times, which is generally very closely aligned with the government and the official corporate positions, okay, this is corporate news. The New York Times published a paper in which they explicitly said two key things. The CDC has been intentionally withholding data on the vaccines and on COVID all the way through the outbreak. Ooh. Okay, and the New York Times explicitly said that the CDC has become politicized. It is functionally a political arm of the administration, of the White House, of the executive branch, and it is no longer functioning as it once was, as an independent arbiter of truth. It is now an integrated political organization supporting the narrative and the political agenda of the executive branch. And so these statements that CDC says this or CDC says that are, per the New York Times, no longer valid. Okay, they have withheld information from physicians and public health officers to advance a pro-vaccine agenda. And they are explicitly a politicized organization in an environment in which the President of the United States, not just Tony Fauci, has made a clear, unequivocal statement on the record, on video, saying if you get vaccinated, you will not get infected. And of course, that whole narrative has just collapsed over the last 3 weeks, with Gavin Newsom getting infected, Justin Trudeau getting infected,
Biden.
Tony Fauci getting infected, and now Joseph Biden getting infected. Okay? These are highly vaccinated, highly compliant individuals, and like many all over the world that have been highly compliant because they wanted to do the right thing, right? They thought they were doing the correct ethical thing, no fault on them. They were following the government. The government was teaching them that they had a moral obligation, not only to protect themselves, but to protect everyone else and the elderly, that they needed to take these vaccines. And so they have done their civic duty. And unfortunately, now the data show that these are the people that are most likely to get infected and have disease, hospitalization, and death, and moreover, because of these things we were talking about earlier, to get repeatedly reinfected or chronically infected.
And longer.
And as you've got the paper, I noticed you picked out that paper, brilliant, from the New England Journal.
I'm prepared.
You are very prepared. So recent paper from the New England Journal, admittedly small numbers. This gets into Theo's world of statistics. This is a small initial report, but the actual, and the authors downplay the data because they don't read statistical significance, but the trends in the data clearly show that the highly inoculated are the virus is persisting longer in them. And many of us know from our friends and family that, and our coworkers, that the people that are getting repeatedly infected are the highly vaccinated. And here's why that matters, is because there are separate data, this whole discussion of what is driving the mutations. And many things are driving the mutations. Viruses mutate, as Theo said in the launch. I mean, it's just intrinsic. Viruses are amazing little evolution factories because they're such large numbers. They have billions of children, right? But there are clear and compelling data that among the spectrum of humans contributing to the evolution of escape mutants, viruses that are able to escape the immune surveillance, particularly of vaccination, one can easily track evolution in people who are immunosuppressed for some reason, whether they have cancer, chemotherapy, innate immune defects, AIDS, not just AIDS, and also these repeated inoculations. It is in the scientific world, just because you can see it here doesn't mean it's not happening there. But you can clearly see it in these people, just like you can with the AIDS virus. With the AIDS virus, one of the fascinating things in virology and immunology is that we've been able to see the evolution of the virus in each individual patient over time. And now we're seeing that same thing happen with these people that have these chronic coronavirus infections. And so what this plays into, and I hesitate almost to say this, but there was such a concerted propaganda effort to make the case that it was the unvaccinated that was putting the world at risk. But the data that I see, I don't want to represent Theo, but the data that I see demonstrates that the highly inoculated and the immunosuppressed are contributing to the evolution in a significant way of escape mutants, whereas those that have the broad-based immunity that comes from the natural infection by the mucosal route seem to be controlling the virus much more effectively, presumably because they're not just trained to respond to spike, but they're responding to all of the whole spectrum. Diversity is good, right? In immune response.
Yeah. But then coming back again, because we still haven't answered that question, how are we going to convey this message to the public?
Yeah,
and I
so
think
for example, your graph, what you make, what are you going to do then with that? You say Rutte, Van Dissel?
So what we've done is I've written a registered letter to the director of our Institute of Health and presenting the results and expressing my concerns, and just with the question, from a precautionary point of view, please reconsider vaccination strategy, because I think this is a real warning. And so it's not that everybody dies. I do a rough calculation, it's 1 in 800. But then again, I mean, these are then...
1 in 800 is a pretty big number.
Yeah.
It's a pretty big number.
But this is...
the myocarditis incidence now is publicly acknowledged by some governments as 1 in 5,000.
Yeah, I know. And so what I talk about, of course, the vaccination campaign that's now going on. That's the nice thing in the Netherlands. It's done in campaigns. So if you have a danger signal, that comes easier to the surface because it's the vaccination is in a small time window, so you can easily
follow it up.
Yeah, and what was I saying? Oh yeah, that's given only to people of 60 plus age. Yeah. So that maybe explains why you have a relatively high number, if it is causal, of people that die, because you also have the very old. And
so this is crucial, and this was something that was pulled out of the early data at least a year ago, and it was one of the logic flaws that I had made and others had made. We criticized the CDC and these other public entities this is more technical talk, not stratifying the risk of the virus, meaning the truth is that virtually all of the risk for death of the virus is isolated in a very small age window of really 65 and above. Okay, that's almost all the deaths.
Yeah.
And so we presumed, I own this, I wrote op-eds with Peter Navarro saying we should focus our vaccination just on these people that need it most and let the rest of the population, more like what Sweden eventually did, acquire natural immunity and save the vaccine rather than driving the evolution of vaccine escapements for these people that needed it most. And then the data came out that not only is the risk of the virus stratified by age, but the risk of the vaccine is stratified by age. And when you do that age stratification analysis, which is what is normally done, but it's been hidden from us, then you find that the adverse events also cluster in these people that are aged, that have underlying conditions. And that sounds like, from what I'm learning from you, is that this excess mortality signal that you're detecting that correlates with the inoculation campaigns may be stratified also by age, and that would be entirely consistent with all the other data.
Which is true. So if I break it up in 3 age groups, then you see that the most of the mortality is in the plus 80.
Which is unfortunate, because they're the ones that need it the most.
Exactly.
But we cannot look away from the truth.
But, Robert, at this point of time, do they still need vaccination? Because we talk about Omicron, we talk about a good level of herd immunity here. And so what is the risk now for the people of those ages?
Which is why, so among other things, I stand as the president of the International Association of Physicians and Medical Scientists. So we're 17,000 that are only physicians and medical scientists, all verified, no nurses, not because we don't like nurses, but it has to do with the positioning with the press and messaging, okay? So that's the basis for our organization. Months ago, we came out with a press conference and a clear, unequivocal statement that one can find at globalcovidsummit.com, where we made a clear, unambiguous statement, in our opinion, as an organization, these vaccines should be withdrawn. Mm-hmm. They are no longer justified on a risk-benefit ratio.
Yeah.
As the person who is responsible for the genesis of this technology, I'm often criticized. Didn't I realize what I was doing? There's no way for me to have known that the normal standards for regulatory development and testing and clinical would be circumvented.
Yeah.
I stand as someone who has intimate, detailed knowledge of the technology and its risks and benefits, the nature of the formulations, the role of the pseudouridine, all of those things. It's my opinion and that of the organization that I represent that the data are now sufficiently clear that, in our opinion, the ongoing campaign for vaccination is no longer warranted.
I agree.
And furthermore, it's our opinion that early treatment saves lives, that we now have a broad spectrum of early treatment options. All of the press attacks about ivermectin or hydroxychloroquine, even if you set all those aside, there are plenty of other agents, the novel agents, monoclonal antibodies, many things. What matters is that our elders, our high-risk individuals, have immediate access to therapeutics if they develop symptoms, just like the president, just like Tony Fauci. The same standard should apply to any of our high-risk individuals. But likewise, we should not continue with this everything deserves the same hammer.
One size fits all.
Such as Pavloxid, which a recent Science op-ed clearly outlines that this protease inhibitor strategy against the main protease, which is the mechanism of Pavloxid, is highly susceptible to vaccine escape, just like to viral escape. And we are observing that. And it was a known risk with protease inhibitors. It is a known risk with HIV protease inhibitors. This is we know all of this science. I sat on the committee at NIH, the foundation for the NIH, called the Active Committee, during the time when these drugs were being tested, the active trials. And it was explicitly acknowledged at that time that this single agent strategy, as a virologist, it was a total setup for evolutionary escape of the virus. And what that means is not that we should not use the drugs.
No, but in combination.
We should use them in combination, and we should use them selectively for the people that need them most. And we have Pfizer, the manufacturer, halted their clinical trials for Pavloxid because it wasn't working, it was not effective in people of average risk. Okay? So we have multiple lines of evidence that one should not just blindly use this drug every time somebody gets infected. We need to use these things wisely.
Yes, like you have to do with vaccines.
Just so.
Okay, thank you both enormously.